We're talking about trust in healthcare, the effects of racism on people in our community, and how that impacts both healthcare and your health, your happiness, and the choices you make, particularly sitting in the doctor's office when they're discussing treatment and therapy opportunities for you. We're speaking with Dr. Hughes Halbert from University of Southern California. You're professor of population and health sciences there at the Keck School of Medicine. You work at the Norris Cancer Center focused on cancer equity, which is to say helping Black people get what Black people need in terms of cancer care. Welcome. What do you think the impact of the idea of trust has on an individual's life and choices around cancer care?
Thank you, Daryl, for having me. I'm really glad to be here. So trust is a really important component of all domains of healthcare and decisions about healthcare. Some of my previous work has delved into the issue of trust as it refers to the extent to which individuals believe or trust what their healthcare providers are sharing with them in terms of their clinical diagnosis and about strategies for treatment options, as well as options for early detection. What's interesting to me about trust is that at the end of the day, we can think about it as being kind of the basis of being based in. So it brings into the conversation how we talk to one another. And one of the things that I think is really critical to trust is there's this notion or component of it where it's really rooted in the ways in which patients and providers share information or don't share information. It has implications for the extent to which patients are willing to provide complete information about what they're experiencing and what they'd like to do. If you can imagine someone who's facing a cancer diagnosis, not believing that the provider is providing the full, complete information, or is withholding information that could be relevant to one's health. So trust is really, I think, a foundational aspect of the patient-provider relationship, but it also relates in a more broader sense to the ways in which communities trust healthcare systems. So, in healthcare systems can be thought of as like the physical system that's providing the care, but also the individuals within the organization who are interacting with patients on a day-to-day basis. And I think about that in terms of the behaviors or actions that individuals, healthcare systems do to demonstrate that they are worthy of being trusted. So has moved from trust, distrust, and now I think into this area where we're thinking about trustworthiness, which is really, I think, brings us to more as I think about it, of a behavioral interaction, and you think about behaviors like actions, things you do and things you don't do, to demonstrate that your behaviors and actions are aligned and focused on someone's well-being and best outcome.
What are the metrics that a patient can use to understand, is this physician in front of me worthy of my trust? Is this hospital or community health center or institution of any sort? Is the pharmacy worthy of my trust?
So communication is really critical. And when I say communication, I mean, do patients have the ability to voice tell their story in their own words? Do providers respond and acknowledge the patient's point of view as part of those conversations? And this is, again, I'm thinking about some of our work that's been published many years ago now, it seems, where we looked at it from like the ability, from a communication and behavioral standpoint about where and how patients feel like they're asked questions, they're listened to, and taken seriously as part of the conversation. So one of the things I think is really interesting is, and then I think it's One of the previous works that I've been involved in was really focused about, and this is something I think healthcare systems as a concrete example can do. So one of the ways in which we can diminish trust is, as one of our priorities has been improving access to and participation in clinical trials among diverse populations. And so there's huge efforts that have been made to share information about the availability and the options to participate. Patients participate in the study, but then the results of the study are not provided back to the individuals and or community. So it creates a process where the questions can be asked, well, what happened as a result of our participation? The lack of sharing feedback and information about what the study found, how the results are relevant to you, to an individual or to communities, is one way we can diminish trust, can facilitate distrust, because you don't know what happened as a result of a patient providing their time and their resources. The other ways, and just drilling down that a bit further, some of our work has also been interested in the perceptions that if individuals participate in studies, they could donate a bio specimen, a sample, like their tissue sample, as a result of their treatment. You don't know what happened as a result of that decision to donate one specimen, their blood or tissue samples. And then you kind of hear where down the line, where companies or investigators have developed really important therapeutic options, one that's not available to patients because of its cost, or it's not available at your center. So that kind of ecosystem can be a facilitator of distrust. So again, it's sort of the idea and the central component is not communicating, not providing information back to patients or to communities to help them understand what their participation in a study resulted in, or the benefits. So those are kind of the things in the research, Rebecca, that in the research area that can be a facilitator of distrust. I think that on the flip side, you want to ask, well, what demonstrates trust, right?
Yeah.
So some of the things that demonstrate trust is I think the word now that we would describe it as being transparent about what will happen in the case of a research participation, what will happen, what the results, how will they be used, and checking in and sharing information about what a research study found. One of the previous work that I did, it was funded by the Agency for Healthcare Research and Quality. We developed a strategy for providing sort of global results about some of the early work that had been done in tamoxifen as a way of just ensuring that African American women who had a personal or family history of breast cancer were aware that this research had been done, the role that how it was relevant to breast cancer issues among African American women. And that was demonstrated to be a way to increase perceptions of trust in healthcare systems. So we think about that as like a potential strategy where investigators have an obligation and expectation that they're going to publish their results in scientific journals. And that's an important dissemination strategy. But if we think to go one step further about how we can include information about the results of specific studies as part of our outreach and dissemination, community outreach and education programs, that could go a long way of enhancing trust, I think, in healthcare systems more broadly defined. I think this is an issue where there's some recognition of the importance of being more systematic and in terms of providing information to diverse audiences in ways that can be that are usable and relevant. So one requirement, for instance, that the National Cancer Institute, I think, has really been a leader in terms of NIH approaches, NIH centers and institutes with respect to implementing a required component for community outreach and education that has the specific purpose of ensuring that cancer centers are addressing the cancer burden in their catchment area. NIH, I mean, having come from a family where my mother died from breast cancer, and we all are touched in our families with cancer, but one of the things that really has resonated with me over the course of my career is my mother was diagnosed in the early 80s. What would it have been like with all of the advancements that we have now? They have been available then, and how would her journey with breast cancer have been different?
So let's talk about that from a patient level. The idea of a Black patient in the prostate cancer world, typically a 60 to 70-year-old guy, maybe 50-year-old guy, walking in a decently sized urban city, walking into the local hospital because his primary care provider said your PSA is elevated. Go talk to the urologist. Rarely will he see somebody that looks like him. There'll be no racial concurrence. Uh, the institution itself has mainly white patients wandering the hallways from this patient's point of view in the urology clinic. Where's that patient going to feel trust, develop a sense of trusting and trustworthiness of the physician and the setting?
Yeah, your question really makes me think about the ways in which the evidence and the implementation and dissemination of patient navigation programs. So patient navigation is at its crux, at its core, is an individualized approach for addressing patient level barriers. There's so many different manifestations or conceptualizations of navigation, some of which is the more clinically oriented nurse navigation will be where an individual who's a provider who's trained and has specialty in nursing works to get patients from one next point of care. The second type of navigation more community oriented, and these navigators are more lay or individuals who tend to be representative or racially or ethnically concordant with the patient population, and really work to serve several different functions. One, to be a resource to help explain, understand, interpret, guide, be a sounding board for patients to ask questions and to get clarification. That can be at an individual level, but it's also, if you think, there's some programs many years ago that were called the Witness Program, and the model, which I think has really been replicated and broadened over time. But the core model is that cancer patients who've gone through the experience tell their story, share their experiences. So some of the ways that this will go back to trust, some of the ways in which I think trust can begin to form or be diminished is as you talk to individuals about their experience, you say, well, did you get this, and this? You're like, well, no, I got something completely different from what you experienced. And so those kind of comparators, will start to raise the question, well, why didn't I get this? Why didn't I hear about this? Why? What's the reason for it? So the Witness Program, I think, is one way to help. One was designed to help provide insight into the sort of the cancer care journey from the patient perspective. So it's meant to demystify the things that happen. And I think also it can create expectations of what you should be getting and what the care should be. And I think that has really been one of the founding principles of patient navigation. But to answer your question, so navigation and some of elements are required as part of the accreditation process I think it's part of the Commission on Cancer. And what that does is says that cancer centers cancer clinics, cancer programs have to demonstrate what are the ways in which they are providing some level of individualized support to patients through navigation. So all of that to say, I feel like I'm going around and around and not really answering your question, which I'm going to get to just now. I think navigation has a critical role in providing ancillary support in a cancer care setting that is more patient-focused and patient-directed, because it really kind of gives the patient an opportunity to talk with someone, share concerns, ask questions, get clarification, as well as have improved care coordination, which I think is essential for mitigating the limited amount of time that patients may have dealing face to face with the physician.
Yeah, and we see that in our Malecare support groups where patients and patients from the community and such are coming to talk with other patients or our staff because somehow reasonably to some extent, they trust us to convey a comprehensive and complete basket of information in a way that they could digest and understand, that they can hear and know that we're hearing, that we're responding to them describing what their endpoints are. If we go back to the clinical trial analogy, where patients tell us what they want because they're not getting it in what should be the person with the MD should be giving it.
Yeah, and I think one of the things that I've I really will just want to make this statement very clearly. Physicians always put patients first. I think that there isn't an intention a desire to not provide information, but I think that there are very real constraints that limit the amount of time, which then reduces the quality of the interaction. And I think as a behavioral scientist, there are some components of like that interaction, that communication that we all have. What's really exciting about cancer care is that we're recognizing that cancer care is really a team activity. It should be done by a transdisciplinary team to help understand best practices for patient-provider communication, understand best practices for when and how to introduce key points along the discussion for cancer care, understanding the patient's lived experiences and how that influences and impacts cancer care. So one thing that I think has been really critical and has where our understanding has grown and continues to grow is that when patients are in a clinical setting, there's a lot of control and influence that providers have. So they can make appointments, they can schedule procedures, and patients sort of meet those, go to appointments, complete procedures. But I think the real test of the impact of cancer care is when patients go home, go back to their communities, because that's where the real test of the patient's ability to manage and deal with issues outside of the clinical setting, where the providers and the healthcare system in the broadest sense isn't really setting the stage and coordinating activities. I think we're now really trying to understand the ways in which the patient's lived experiences influences cancer care, influences their lived experiences, where and how you live, or social determinants of health, influences one's ability to access healthcare, influences one's ability to complete diagnostic and treatment recommendations, and determines and influences and shapes the quality of survivorship. And so those lived experiences, we can think about them within the broader shape of neighborhoods within the states and communities within those states. There's a lot of variability, which shapes the lived experiences that patients bring to their cancer care. So one of the things that I'll share with you, work that I was doing in Philadelphia while at the University of Pennsylvania, the goal for this study was and this was, I guess, in the early 2000s, trying to understand women's experiences with their breast cancer diagnosis and treatment. And I'll never forget it, because the participant shared that cancer is just one of the stressful things that she has to deal with in the course of her life. And so when you think about it in that kind of perspective, when cancer is such a profound clinical healthcare experience, can you imagine if someone is living a life where their experiences where cancer is just one of the things that they have to do? And I think that has really been a foundational core component that has guided my own research and has really began to think about the lived experiences and how we can understand that better and how we can address those issues as part of cancer care. Because if someone isn't able to pay their bills, doesn't have access to healthy food, those kind of things are, I think, are going to be the priority in one's life. And I don't think we would disagree that that should be the priority. But if we think about sort of health and well-being and the potential and how that can be reduced by just the social and lived experience, living environment, when that is challenged with the cancer diagnosis and treatment, it creates a situation, I think, and the opportunity for certainly reduced at for challenges across the entire continuum of cancer care.
Totally. Before we close this out, I don't want you to leave without discussing some of your understanding of genetically targeted care, precision medicine, and the opportunities for racism to infect that in a toxic way for people of color. Um, so, just based on what I just said, what do you think?
So one, I'll say, I think precision medicine has such important potential because when the initiative was first announced, I saw it as based on the description as like really understanding genetic, environmental exposure, and lifestyle behaviors and their combined effects. So I felt like it was a real strong potential for a deeper, greater, more comprehensive understanding of the ways in which different variables influence and interact and have direct impact on cancer risk and outcomes. I believe and I'm confident that we're now integrating more of environmental exposures as well as lifestyle behaviors and risk factors that are now being incorporated into the precision medicine approach. I think what we still struggle with, if we think exclusively about genomics and genetic science, is that much of the work that's being done are based on biorepositories, resources that have limited diversity in terms of race and ethnicity. And what the cumulative effect of doing research and doing the basic discovery science on the resources that have limited diversity is that we really don't know the influence of a particular signaling pathway, genetic marker, risk factor within the broader group of participants, of individuals. So we think about how that plays out of doing basic discovery science and using resources that are not diverse, is that the treatment and the therapies are developed without the representation of the patient populations that it will actually be implemented in. If that happens, if the new drug was developed and we don't know all of the effects on different patient groups, then it's like we've made some really fundamental errors in the investment, because we now have a drug that was a therapy that was developed and we don't know how it works, if it will work in the same way or as intended. So I think so in my mind, there's like genetically targeted care, but I think I think about it as genetically informed care that's not really very informative. It's not inclusive. So it lacks the inclusivity that's needed to understand its performance across all.
No, I think that's spot on. I mean, I think there's a misunderstanding of this idea of precision medicine as if like this is a way to leap over the barrier of trials that were basically white patients being investigated and don't reflect others, don't reflect the black man's genetic background, genomic background experience and their environment and everything else. It doesn't necessarily leap over that barrier. And we're not there yet, or we're not
I,
even asking those questions.
I agree. And so I think one way several leaders in the field are aware of this. And I think one thing that significant efforts are now being implemented to one, address the lack of diversity in genomics and the resources that are used to develop genomics.
Super. Finally, a Black man sits in front of you over coffee, just diagnosed, perhaps a colleague or a friend, and says something to the effect like, I don't know who to believe. I don't know what, I don't want to see this doctor. I don't want to deal, I don't trust any of the meds. I don't trust the test. They want to do radioligand things, stick radiation in me as well as on me. I mean, it's not enough to take an x-ray. You have to actually stick the radiation through your veins and such.
Well, I mean, I think one thing that the way I would respond to that if someone were sitting in front of me is that one is, it is as patients we all have rights as patients, as healthcare consumers. And one thing that I think we have to sort of be comfortable with is there's always, if you fundamentally, you don't, you're not, you can, I'm just thinking about the sequence of the words I want to say, because I think it's, we don't, we do have autonomy and agency and choices. And I think if patients, if someone said that to me, I would say if you fundamentally don't believe what they're saying, then you need to find another provider. You need to find someone that you trust. And and the question is, well, how do you do that? I think one of the things that early in my work, I was interested in family communication about genetic testing, but really the interest was in family communication. And I think what is so important now is that we are able to seek out from trusted individuals to hear about their experiences. And cancer used to be a diagnosis that people didn't talk about. And men in particular didn't talk about prostate cancer and about their experiences with prostate cancer. But now I think we are turning a corner where men are willing to talk about their experiences. And so I think we have to have the opportunity to open the door and create the space for that dialogue. That's why I think groups such as your organization are so important, because it creates a space. I think one of the things that we can do we can think about how to do more systematically is make those resources and opportunity that information more widely available. So if you're not comfortable talking to me or talking to someone that you can access information on the internet, cancer centers have the facilities and the resources to provide space for patients to access that information. And so I guess my response would be, I think we're past the point of saying, well, I'm doing this just because my doctor told me to. I think we have to be empowered and empowered our family, friends, and our colleagues to say, if you feel like you're not getting what you want, what you need, then ask questions. Patients have control. It's not like the doctor can just do things to you and do things without your approval. I mean, and as a, I think I appreciated that more once I started my family and was responsible for making decisions for my children, healthcare decisions, because you really do have to be the one to question and say, that just doesn't feel right, doesn't sound right, I don't believe it. And that's okay to ask those questions and to be very forthcoming. Trust is based on interpersonal relationships. And I think if thinking of my own experience where I was, I'm not going back because I think they're not telling me everything I want to know, and they're not giving me the space to answer the questions. They're dismissing what I'm asking. And so I think that what I don't know is how, as patients, and this is something where I think advocacy groups and support organizations can really be, because I don't know that there's a mechanism for patients to say, Dr. X, Nurse X didn't respond to my questions and I have concerns and I want something to be done about it. how do we improve upon that physician's behavior?
Wonderful way to close. Dr. Hughes Halbert, thank you for visiting with Malecare. Thank you for visiting with our community, and ever so grateful for the work that you're doing and continue to do. And welcome to Mailcare's Faculty Night.
Thanks so much.